Hello everyone, I am Mohammed Hamama, and this is your ASCP preparation camp. In this camp, we will go through each topic on the ASCP lecture list. In today's video, we delve into the second part of hemorrhagic disorders and laboratory assessment. Today, we're delving into the intricate world of liver disease coagulopathy. We'll also tackle chronic renal failure and hemorrhage, vitamin K deficiency in hemorrhage, and autoantibody inhibitor and acquired hemophilia. Let's get started. Liver disease, a complex terrain where bleeding can wear many faces. From localized to generalized, mucocutaneous to anatomic, let's unpack the layers. Picture this: esophageal varices from chronic alcoholic cirrhosis causing localized bleeding, a serious complication. But what happens inside the liver? It's a symphony of disrupted coagulation factors and regulatory proteins. In liver disease, vitamin K-dependent factors 2, 7, 9, and 10, as well as control protein C, S, and Z, are produced in forms that can't participate in coagulation, falling below hemostatic levels. Factor 7 takes the spotlight, being the first to decrease in early liver disease, leading to a prolonged prothrombin time, PT, a sensitive early marker. Declining factor 5 activity becomes a specific marker of liver disease, untouched by vitamin K deficiency. It helps differentiate liver disease from other culprits. But it doesn't stop there. Fibrinogen, usually elevated in early liver disease, can turn dysfunctional, dysfibrinogenemia, in advanced cases, causing soft tissue bleeding. In the end stage, fibrinogen levels may plummet, a telltale sign of liver failure. Platelet abnormalities in liver disease. Let's shift our focus to platelets. About 1/3 of liver disease patients face moderate thrombocytopenia, platelet counts below 150,000 per milliliters. Portal hypertension and hepatosplenomegaly play their part in sequestration and shorten platelet survival. Now, here's an intriguing twist. In alcohol-related cirrhosis, acute alcohol toxicity doesn't just stop at the liver, it inhibits platelet production. Platelet aggregation and secretion take a hit, but occasionally, they may surprise us with hyperreactivity. How do we anticipate the risks? Aggregometry steps in, helping us gauge the potential for bleeding and thrombosis tied to platelet abnormalities in liver disease. Disseminated intravascular coagulation in liver disease. In the intricate dance of liver disease, chronic DIC takes the stage as a significant complication. Why? Because the liver, in its struggle, produces fewer regulatory elements, paving the way for an imbalance. Reduced antithrombin, protein C, and protein S open the door to chronic DIC. Add activated procoagulants from struggling liver cells, and you've got a complex coagulation scenario. The plot thickens in cases of liver cancer. Hepatocytes might play the antagonist, producing procoagulant substances, triggering chronic DIC, and setting the stage for potentially dangerous ischemic complications. Now, let's fast forward to acute, uncompensated DIC, a condition demanding our attention. Prolonged PT, PTT, and thrombin time, coupled with reduced fibrinogen levels and skyrocketing D-dimers, it's a diagnostic ensemble. In chronic DIC, keep an eye on the D-dimer assay, it might be your sole elevated test, a silent marker of unregulated coagulation. To resolve DIC, we need to address its roots, but sometimes, a temporary correction is a must. Enter the cavalry: red blood cells, plasma, prothrombin complex concentrate, tranexamic acid, platelet concentrates, and antithrombin concentrates. Each plays a vital role in stabilizing the tumultuous hemostasis. But what about those lab tests? Hemostasis laboratory tests in liver disease. In liver disease, chronic or compensated DIC takes center stage, driven by the liver's struggle. It's a condition where regulatory elements like antithrombin, protein C, and protein S take a hit. As if that weren't enough, activated procoagulants released from deteriorating liver cells join the chaos, creating a perfect storm. The liver, impaired and overwhelmed, fails to clear activated coagulation factors. Now, let's talk about a plot twist. In cases of liver cancer, be it primary or metastatic, hepatocytes might play the role of the antagonist. They produce procoagulant substances, triggering chronic DIC and paving the way for ischemic complications. Fast forward to acute, uncompensated DIC, the urgent scenario. It's marked by prolonged prothrombin time, PT, partial thromboplastin time, PTT, and thrombin time. The fibrinogen levels plummet below 100 mg per deciliter, and D-dimers soar. It's a diagnostic symphony. In chronic and compensated DIC, keep an eye on the D-dimer assay. It might be the lone elevated result, silently signaling unregulated coagulation and fibrinolysis. Resolving DIC isn't a one-size-fits-all. It requires addressing the underlying cause. But, in the interim, we can temporarily correct hemostatic deficiencies. Enter the cavalry: red blood cells, plasma, prothrombin complex concentrate, tranexamic acid, platelet concentrates or antithrombin concentrates. Now, let's explore the detective work, the hemostasis laboratory tests in liver disease. PT, PTT, thrombin time, fibrinogen concentration, platelet count, and D-dimer concentration, they unveil the mysteries. Factor V and 7 assays become our Sherlock Holmes, distinguishing liver disease from vitamin K deficiency. When it comes to confirming systemic fibrinolysis, we look for plasminogen deficiency and an elevated D-dimer. Sometimes, the reptilase time test, with a touch of Bothrops atrox venom, helps confirm dysfibrinogenemia. Chronic renal failure and hemorrhage. Chronic renal failure, regardless of its cause, often brings along platelet dysfunction and a tendency for mild to moderate mucocutaneous bleeding. Why? Well, it seems platelet adhesion to blood vessels and aggregation hit roadblocks. Imagine a coating of guanidinosuccinic acid or dialysable phenolic compounds on our platelets. But fear not. Dialysis, erythropoietin, red blood cell transfusions, and interleukin-11 therapy step in to address anemia and thrombocytopenia, reducing the risk of bleeding. Now, let's talk about the plot twists: hemostasis activation syndromes. They deposit fibrin in the renal microvasculature, affecting glomerular function. Think DIC, hemolytic uremic syndrome, and thrombotic thrombocytopenic purpura. These, despite being tagged as thrombotic disorders, often pave the way for thrombocytopenia, upping the ante on mucocutaneous bleeding risks. Lab tests for bleeding in renal disease. They provide limited information, with the bleeding time test often unreliable. But fear not, platelet aggregometry may hold the predictive key. PT and PTT. Expected to be normal. Managing bleeding in renal failure considers the severity. Renal dialysis, a temporary platelet activator, may improve function, especially with well-controlled anemia. Enter desmopressin acetate, DAVP, intravenous or intranasal. It boosts von Willebrand factor, VWF, aiding platelet adhesion and aggregation. But a word of caution: platelet inhibitors like aspirin? A big no-no for renal failure patients. Now, shifting gears to another kidney-related bleeding concern, nephrotic syndrome. Nephrotic syndrome, with its increased glomerular permeability, dances hand in hand with conditions like chronic glomerulonephritis, diabetic glomerulosclerosis, lupus, amyloidosis, and renal vein thrombosis. Picture this: low molecular weight proteins doing a graceful exit through the glomerulus into the filtrate and urine. Coagulation factors 2, 7, 9, 10, and 12 make cameo appearances in the urine, along with the regulatory proteins antithrombin and protein C. But wait, in 25% of cases, the loss of regulatory proteins takes the spotlight, leading to a dance with venous thrombosis. We're delving into the world of vitamin K deficiency and its link to hemorrhage. Buckle up for some fascinating insights. First stop, the tiny world of newborns. Did you know they're constitutionally vitamin K deficient? It's true. But don't worry, routine vitamin K administration swoops in as the superhero preventing hemorrhagic disease of the newborn. However, here's a twist. Breastfeeding can extend this deficiency due to maternal antibodies. Let's uncover more. Now, let's talk about Coumadin, the troublemaker in the world of vitamin K. These coumarin-type oral anticoagulants love to disrupt our vitamin K-dependent coagulation factors. Fun fact: Coumadin overdose is a common culprit behind emergency department visits related to bleeding. And ever heard of superwarfarin? It's a key player in rat poisons, demanding repeated vitamin K administration. Detecting vitamin K deficiency is like putting on your investigative hat. Start with clinical suspicion, backed by prolonged PT and, if lurking, PTT. Engage in mixing studies with pooled platelet-free normal plasma. It's like Sherlock deciphering clues, revealing factor deficiencies. Specific single-factor assays then step in, unveiling low factor 7 and the subsequent decline in factors 9, 10, and 2. Time for action. Standard therapy kicks in with oral or intravenous vitamin K. Keep tabs on recovery through PT or INR. But in the ring with severe bleeding, reinforcements like plasma, activated/non-activated PCC, 4-factor PCC, or factor 7 might make an entrance. Monitoring the effectiveness of these interventions becomes an art. Enter TEG or TM, or the trusty PT or INR for indirect insights. Autoanti-8 inhibitor and the intriguing world of acquired hemophilia. Let's unlock the mysteries together. Autoantibodies inhibiting factors 2, 5, 8, 9, 13, and VWF are like silent disruptors in non-hemophilic patients. But today, we spotlight autoanti-8, the maestro behind acquired hemophilia. In the spotlight, autoanti-8 takes center stage, especially in individuals over 60, often without an apparent underlying disease. Acquired hemophilia, diagnosed by detecting this autoantibody, sometimes links arms with conditions like rheumatoid arthritis or systemic lupus erythematosus. Acquired hemophilia might wear different masks, triggered by pregnancy, emerging a few months post-delivery. Treatment involves immunosuppressive therapy, and interestingly, post-pregnancy cases often bid farewell spontaneously. With an incidence of 1 per million people per year, acquired hemophilia unveils sudden and severe bleeding, dancing through soft tissues or the gastrointestinal and genitourinary tracts. Unfortunately, it remains fatal in at least 20% of cases. Now, let's peek into the lab. When faced with potential acquired hemophilia, our arsenal includes clot-based assays. PT, PTT, and thrombin time take the stage. In the presence of a factor 8 inhibitor, expect a prolonged PTT, while PT and thrombin time keep their cool. Factor assay reveals less than 30% activity, sometimes even undetectable. Enter the mixing studies, a detective's tool. PTT prolongation, initially corrected by normal plasma, comes back after a secret incubation, revealing the temperamental nature of factor 8 autoantibodies. The kinetics of these inhibitors tell a tale. High-avidity ones show immediate PTT prolongation, skipping the waiting game. Type 2 kinetics showcase the nonlinear dance between autoantibodies and factor 8, with early rapid loss and residual activity. Quantifying the mischief. That's where the Bethesda assay waltzes in, helping clinicians choose the right bleeding control therapy. Repeat titers become our compass to monitor responses to immunosuppressive drugs, though not necessary for managing bleeding symptoms. Factor inhibitors beyond autoanti-factor 8 and exploring how to manage acquired hemophilia. Factor inhibitors are like silent disruptors in the world of clotting. First on our list, anticoagulation factor 2 antibodies, found in about 30% of lupus anticoagulant patients. Surprisingly, despite lupus anticoagulants' usual association with thrombosis, patients with antiprothrombin antibodies may experience bleeding. Watch out for a prolonged PT and reduced prothrombin activity. Antiprothrombin antibodies unrelated to lupus anticoagulant are rare. But our tale doesn't end there. Isoniazid treatment for tuberculosis has been linked to the development of factor 5 and 13 inhibitors. And remember the days of topical bovine thrombin? Exposure to it or fibrin glue could lead to antibodies to factor 2, thrombin, and factor 5. Thankfully, the prevalence has decreased with the shift to recombinant human thrombin. Autoanti-X antibodies are uncommon, with amyloidosis potentially causing factor 10 deficiency. It's a rarity, but in the world of hematology, expect the unexpected. Acquired inhibitors often reveal themselves in immediate mixing studies, and to gauge their strength, we turn to the Bethesda procedure titers. Now, let's talk management. When it comes to acquired hemophilia, quick thinking is key. Activated PCC or factor 7 can effectively manage acute bleeding by bypassing the factor 8 inhibitor. For those with low inhibitor titers, desmopressin acetate, DAVP, or factor 8 concentrates might do the trick. Immunotherapy takes the stage after bleeding control, working to decrease inhibitor titers. In severe cases, plasma exchange is an option, although its response is less predictable compared to immunosuppression. Acquired von Willebrand disease. Buckle up for this captivating journey. Acquired von Willebrand disease shares its symptoms with the congenital variant but comes with its own set of twists. It's linked to various conditions such as hypothyroidism, autoimmune disorders, and lymphoproliferative diseases. The causes? Reduced von Willebrand factor, VWF, production, the presence of autoantibodies, or the adsorption of VWF to abnormal cell surfaces. The symptoms? Picture this, moderate to severe mucocutaneous bleeding. It might raise suspicion in individuals with recent onset bleeding and no significant medical history. But how do we catch this elusive condition? The partial thromboplastin time, PTT, might offer a clue, moderately prolonged if VWF reduction significantly affects coagulation factor 8. Please don't forget to subscribe our channel, activate notifications to get our new videos. Press like, leave a comment or if you have any question below and share the video with your friends.